My name's Cody Rogers. I'm one of the hospital doctors down in Cox Branson. Spent some time with Justin Higasek. I don't know if I've met anyone else in here, but heard some of you how to test, which works out because this probably won't be a super academically rigorous lecture. So we'll just kind of jump into it. Again, I work in Branson. We're just going to talk about a couple different things. So hence the potpourri nomenclature. Yeah, so kind of relevant disclosures. There's not a lot of them. Nothing financial. I do love Jesus. That's a big driver for why I do anything, I think, and strive to do it well. I am also kind of bullets 3 and 5 are tied together. So I got trained in family medicine. I work in a hospital and a community hospital, so fairly limited scope, and so you'll get some of that here. I am a newish father, 5.5 months child, so you'll see some pictures of him. He's the cutest baby in the world. But so I guess yeah, plan just kind of look at some cases, some like actual patient cases, but then some like questions from the floor that you get. So kind of more like internal medicine, hospital medicine geared. I would love it if you all went into family medicine because I do think that's the greatest specialty there is. You can do a lot of things with it. Like work in a hospital, you can do what my wife does. We work in a clinic, see a lot of kids, so just a lot of variability. But I guess it's all right if you don't. And then yeah, at the end there's just some helpful resources to kind of go through. And just I guess yeah, I didn't put much about myself necessarily, but I most of my life was in Arkansas. I was actually born in Kenya because my parents were doing mission work over there, East Africa. Went to college in Arkansas, went to med school in Arkansas, and then did residency mostly through the Cox system in Springfield. And then went and did a fellowship in international medicine, came back to this area, started working at my current job in Branson, which I work nights only. So that's also something to talk about. But yeah, so that's kind of who I am and what brought me here. But just go ahead and join me on my shift as we walk into the night shift. First case, a lot of information here. I think I may be, no, just kind of highlighting. So kind of, I tell people that rotate with me, like variability is the name of the game. Well, you'll see a lot of different stuff, and it'll each night will look pretty different. But so these are some cases and some questions that I got from nursing staff on shifts that I had. But this first patient, so she's a 52-year-old female. She actually presented to the urgent care first. Their oxygen was low, so they said, no, please go to the ER. Our chief complaints, feeling unwell, so pretty nonspecific. A little bit more history. She's had 5 days of increasing weakness, cough, body aches, fever up to 102. Got a wet cough, coughing up green sputum with some blood in it, not every time. Got left-sided chest pain, worse with deep breathing, and then kind of these other blurry vision, nausea, poor intake, headache. So it feels unsteady, not swelling. Yeah, some pertinent negatives. So I gotta just kind of pause right there. You should probably be thinking of a couple different things because, you know, part of my goal with a patient like this is to, you know, what's going on here and then what do we need to do about it. So feel free to just yell out some things like what's possibly something that you could have with just this information that you have right here, or some diseases that could be going on. Yeah, pneumonia's up there. Good one. What kind of pneumonia? Maybe big bronchitis, bacterial, maybe. Maybe there's some other, yeah, 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 absolutely. What if this happened in 2021? Change anything? I mean, it's still going on now, but COVID, it could be COVID, could be flu. I think with the like the chest pain too, it kind of makes you think about some things. All right, oh, is it not? Oh, nice. Okay, perfect. Thank you, Bethany. Yeah, but other things to kind of keep broadly, so like could be something going on with her heart, could be like a blood clot going on in her lungs, could be costochondritis plus a fever. That could certainly do all those things. But let's keep moving forward. So kind of the really objective information up top, and then the bottom is like what I recorded, so it's quote unquote objective. But the big things that stand out is that she is still febrile. She does have a high heart rate. She's got uh, heart rate, yeah. Respiratory rate was actually normal, and she's satting. I wrote it down up there somewhere, but she was on 4 liters nasal cannula. Yeah, she's setting 91%, which isn't like great, but not the worst ever. But that's on 4 liters. So we turned it off to see what would happen. She dropped to 88%. So we put her back on some more oxygen. She's got right-sided rhonchi, diminished breath sounds at the right base. So rhonchi, in my head, it crackles, wheezing. Theoretically, you can tell a difference there. Crackles are like that crispy, like if you dump milk on rice cereal and it makes those popping sounds. Wheezing is that kind of more musical. And then rhonchi in my head is kind of everything else. So it doesn't really fit into one of those categories, but doesn't sound like normal breathing. But the rest of her exam was fine. So yes, we kind of talked about kind of thoughts that we're thinking. So what, and feel free to, I don't know how to the chat box, but other things to be thinking, other different, yeah, we talked about differential a little bit. Other tests to get, tests that you want to get at all, let's say you don't have anything yet. Usually when they come to me, they've gone through the ER, so they have all of this that I'd want to order. But what should we get to kind of work this up? Yeah, chest X-ray, very reasonable. Anything else? Easy, yeah, perfect. Yeah, sputum culture, good idea, especially if he's coughing stuff up. Just a CBC, any other lab work you guys want to get besides the sputum culture and the CBC? Yeah, CMP, very reasonable, kind of see where her kidney function's at, yeah. Yeah, I think lactic acid is a good idea. But yeah, we didn't, but yeah, that would be a good idea too. Yeah, blood cultures, so. And then kind of just point out, I didn't talk about this too much in like the actual case, but so one big thing or a big push right now is like sepsis and like the definition of that and what to do about it. And we actually, probably fine to say this, but we are not catching sepsis as often as we should in the hospital. So there's definitely been a even larger push in Cox to kind of catch it early and do something about it. So that SIRS criteria, which is like a high or low white count, high or low temperature, and then respiratory rate and heart rate. So she meets at least 2 of those right off the bat because of her fever and heart rate. Don't know what her white cell count is, but so she meets SIRS criteria already. She's got an infectious source, probably pneumonia in her lungs, like we talked about. So she really needs to like have the ball rolling, get some fluids going. 30 milliliters per kilogram bolus is like the initial push, and then and then start antibiotics early. And the thing is, like if you think, oh, maybe it's not infectious, and you don't do that, and then later it is infectious, it turns out to be infectious, and you've missed it, and you're already late, and their mortality is going to be higher. So, I'm gonna move this. That did kind of come off the screen a little bit, but so this is the actual objective data. So this came from the lab. I don't know if you can see everything on here. So actually her white count's normal, which is strange, but she's got elevated segments and bands, which bands are just immature cells. So she's got a little bit of infection going on because things are technically left shifted. Sodium, potassium are like a hair low. And then her lactic was also actually surprisingly normal. So good, I guess, but she still is septic just based on what she's got going on. So then got a chest x-ray, but we'll just kind of pull it up here. So I thought this was kind of a weird catch. I don't know. Can you guys see that all right? Is it possible to turn these lights off? Is it this switch over here? Okay, I'll just turn this off. Turns all of them off. Sorry, guys. When I try to read x-rays, I try to be fairly algorithmic, which I'm not all the time, but there's different algorithms to use, but kind of ABCD, like airway, breathing, looking at the lungs, and then circulation, looking at the heart, and then diaphragm, and then everything else. But I'll be honest, this one was a little bit tough for me because I heard stuff on the right. She's got maybe like this line here. I don't know if that's new or not. She does have, and she's got her heart over here. And so that, I mean, heart looks okay. It doesn't look technically large. But I don't know if you guys, how well it's coming up, but you guys see those like And sorry for the people on the screen, or on Zoom, but you guys kind of see those like darker traces out through there and then over on that side. So those are air bronchograms. So that's indicative of pneumonia. And actually had a video of CT scans which aren't pulling up, so sorry about that. But it is pretty clear to see she's got a little bit on both faces actually of consolidation. And so and with that CT scan, they also got a CT angiogram to rule out any pulmonary emboli. Yeah, so she definitely has pneumonia, and that's one video. That's another video. So pretend there's a CT scan there. So that's this patient. Here, I'll turn this back on. I guess one thing, I guess maybe did it cut it off there? Yeah, so we did cut it off on the bottom, but or we can look, here's the chest x-ray the read that they gave us, left lower lobe pneumonia, small bilateral pleural effusions, and the CT scan, mentioned again, atelectasis and pneumonia on the bottom. It did cut it off down here, but this was like, I think in November, so kind of height of flu season. She also had influenza A. So the diagnosis she earned were pneumonia, influenza A, and then she's septic, and just a little bit of electrolyte abnormality. So we started with that, ceftriaxone 2 grams, and azithromycin, and with Tamiflu, or also Tamivir, is the non-trade name. And we kind of talked about the workup that she got that hadn't resulted. She got the 30 mils per kilogram bolus. Mucinex is just an expectorant, guaifenesin, and then the acapella. I don't know, you guys have rotated in the hospital, so you've probably seen that. It's just kind of like a little device that causes them to cough up, use their lungs a little bit more. Pulmonary toilet or pulmonary hygiene, as they'll say. So yeah, that's her. And then kind of fast forward, I think she spent about 3 days in the hospital. Her blood cultures actually were negative. Sputum culture was positive for this Candida tubulonesis, which honestly is probably just a throwaway. Like, it was probably in her mouth and caught it on the sputum culture. Her urinary antigen, though, and we'll talk about this a little bit, it was positive for strep pneumoniae. It's interesting that that was positive there, but not positive anywhere else. But it's helpful because then we know what we're treating and what to do with that. So she got sent home on cefdinir, which is a 3rd generation cephalosporin oral, and then Tamiflu 75 milligrams. So we kind of talked about that some, kind of went through that fast, just highlighting a couple learning points, and we'll go through these. So did this lady really need Tamiflu? That's a question to ask. How long should we do antibiotics? Where's the procal? And then the urinary antigen, we'll talk about that. So before we jump in, do you guys have an opinion or a thought on oseltamivir, Tamiflu, or medications for influenza, and when to do that or not? Sure. Sure. Yeah. So great. That's kind of the answer. Yeah, and so this is from the IDSA, Infectious Disease Society of America. Basically, and a little bit different because in the outpatient setting, yeah, if it's been more than 72 hours or 48 hours, is it going to be any benefit? Probably not. Inpatient, if they're admitted for any reason for flu, you probably should just go ahead and treat them for it. And so she had both of these. She had pneumonia, which probably brought on by the underlying flu infection. So you could probably argue to not give it and be fine, but we elected to because she was so sick. Yeah, so those are like their actual recommendations there. But again, the big thing is if admitted to the hospital, or if they've got like high risk of complications, like they're immunocompromised and it's been longer than the 48 hours, reasonable to give. How long for antibiotics? So kind of so I feel like when I went through, it was like 14 days for everything for everybody. And now there's kind of more data saying that it's probably not necessary to treat them for that long. So, and it's kind of tough because you guys are going to be under people for a while, and they'll probably tell you, go ahead and do this. You can just say, yes, sir, yes, ma'am. But kind of when you go out and practice, really, again, like they've done studies that have shown that do it for 5 days, they work just as well as 10, and then everybody's getting less antibiotics. It's less costly, and then so I think just all around better. So again, speaking to kind of inpatient, outpatient, I think fine's pretty much always going to be fine for outpatient, or five's going to be fine for outpatient. But in the hospital, you have people intubated, being ventilated through there for like maybe a couple weeks at a time. And so the IDSA says like do at least 5 days and then continue it until like you see signs of clinical improvement. So just those things there. Procalcitonin was not ordered on this lady, which we really have kind of stopped doing at Cox just because we were ordering them a lot and then doing nothing with it. And so like spending money, getting a lab test with more data, and then just kind of throwing it out the window. Because we think someone has pneumonia, we get a Procal, it's low, and be like, well, I still think she has pneumonia, or we wouldn't think she'd got one, has pneumonia, get a Procal, it's high, and then we wouldn't start necessarily antibiotics for that reason alone. And so the kind of the recommendation from IDSA also is that you can use that like serially in the hospital to say like, okay, the procalcitonin is dropping off. We can assume that they're getting better. Let's hold off antibiotics further. That's the IDSA recommendation. But I think again, evidence is not great. It's kind of muddy. We've quit using it. I don't use it anymore. So that's what I'd say about that. And then urinary antigens. Have you guys heard of that? Seen that before? I don't know how common that is in like the testing world and students, but basically, I mean, it is what it is. Like it's antigens that they can find in the urine. The two ones you can test for are Streptococcus, like that, or yeah, Strep pneumoniae and Legionella. They're actually like pretty great tests. I didn't think they were that great, but I was kind of researching this. We do get them all the time because they're cheap and easy to get, and kind of like that case demonstrates. These are positive. That's helpful to know. And when everything else is going to be negative or probably not related, like the Candida and the sputum culture. So pretty quick turnaround, pretty high specificities too. And so if that's positive, then you're like, okay, this is what it is. So that's them. So you finished up, you're in the middle of writing the note, and you get these two back-to-back pages from nursing staff, which is these were actual pages copied and pasted from what they had messaged. So 124, it's a patient room in the hospital. Manual blood pressure was 180/80. I don't have any PRNs for her. Critical care 12, blood pressure saying mid 180s. I don't have any PRNs. It's nice because he gave a little bit more information. What's the heart rate? This is the medicine he gets. You want to treat that or not? So systolic of 180. I mean that's high. All right. Let's see. I don't know if you guys saw the other side. Thoughts? Do you want to treat that? What do you want to do with that? How should we treat it if we should? And I will say it's different, and this is kind of the point to make. So inpatient, outpatient, different goals, and different things to do about it. So if someone walked into the clinic with 180/80, you're not necessarily going to send them straight to the ER to get admitted for blood pressure control, and that's kind of the thought there. And so if they're in the hospital and they've got a 180/80, do you really need to bring that down to make all of their blood pressures 140/80 or 110/? Yeah, and the kind of the thinking on my head is that someone's walking around all the time with a 180 systolic, over time that's going to cause damage to their vessels and everything. But if they have that a couple times in the hospital, the rest of the time it's 140s, probably not going to have it long enough to develop the pathology. Yeah, so there's not a like all inpatients need to have this number blood pressure, and most of the time it's going to be high for another reason. So I think we're going to talk about that. But so yeah, this is just a little blip it from up to date. No benefit to patient care. They've done some observational studies, and they do show that patients that have asymptomatic hypertension in that kind of 180s range where they get IV treatment for it, they have worse outcomes. So they have longer hospital stay, heart attacks, and damage to their kidneys. So if you think about that, I mean, it makes sense because if someone's used to living 180 and then you drop to 140, you've like shut down a lot of their perfusion ability, and so then they have worse outcomes. So just wanted to throw this in there, kind of little caveat. Nothing in medicine is ever 100%, but there are some times where you do want to acutely lower it. And so not necessarily exhaustive list here, but so like if you've got an acute stroke, about permissive hypertension, and again, same pathology, pathophys, where you want it blood pressure riding a little bit high to get perfusion to those areas that don't have great perfusion otherwise. But if it's like too high, like 240, then you might want to bring that down a little bit. or if they're getting a reperfusion therapy, you want that goal a bit lower. But acute stroke and aortic dissections and intracerebral hemorrhages, so none of these would stay at Branson. So I don't really take care of that, and that's part of the caveat of working in a community hospital. Like that's would be terrifying to take care of someone whose aorta is dissecting. But you want to keep it really low because all that pressure just continues to tear. So that's just a highly morbid condition. Yeah, but again, if you think the high blood pressure is causing the problem, then sure, you want to bring that down. So if they got heart failure that's from a hypertensive emergency, um, or like if they got press where their blood pressure is high and it's tearing up the back of their brain, you'd want to lower that. But again, just all comers, people that are maybe walking with pneumonia that have a high blood pressure, you don't necessarily need to treat. So is that making sense? Tracking okay? So yeah, so then invariably both of those nurses are going to want a response, even if there wasn't a question in it. So what I tell them to do is just like treat the other conditions, like if they're vomiting, let's fix that. If they're super anxious, let's try to talk them down a little bit, and then just check in an hour. And invariably, anecdotally, that works. You talk them down a little bit, check in an hour, and at that point, their blood pressure is 140. So if you had given them some medicine that's going to last longer, you just drove it down lower. It should cause an AKI. So case two, still working on your note from your first case, and they paid you with the second one. So this is a 36-year-old male. He's coming in. Chief complaint is a suicide attempt. So you get some history from the ER. You go down and see him, and you spend some time talking to the patient. So he says he doesn't remember everything that brought him in. Have you guys? Has everyone's rotated in the hospital? I assume at this point, it's late in the game. Have you guys? Oh, I guess that's waiting on psychiatry. Have you guys all rotated in psychiatry or experienced with that? Okay, so getting some no's and yes. So fortunately, unfortunately, anywhere you rotate, you're going to get some psychiatry. Yeah, again, if you like that or don't. But so this guy, this is kind of an interesting case. It's terribly sad, but it's also medically interesting because 36-year-old male, no other health problems. Why is he getting asked to admit to the hospital if all he's got is some suicidal ideation? This is difficult because again, he doesn't remember everything. He says he's not suicidal, but the report I got is that he was having some issues, argument with his wife, ran to a balcony, was actively trying to jump off. Bystanders grabbed him and called police. So then it's like, well, it's hard to say that you're fine to go home if that's really what happened. So incidentally, and this is more where I come in here, but he had a infection possibly on the left side of his thorax. He said it's painful. It's been present for about 3 days. Didn't have any other symptoms with it. And again, did continue to deny suicidal ideation. So there's some more history about him. Again, nothing, effectively no problems, no medical history, no issues. So yeah, really thing to note here. So this rash, dermatomal maculopapular with vesicles on the left side of the thorax. Have you guys seen shingles? Anyone had shingles? Okay, yeah, good. It's very painful. It is like painfully debilitating, but that's a pretty. This is not that patient. This is ripped from the internet, specifically dermnetnz.org, which is a really good website for dermatology if you guys are interested in that. But that's about what his looked like. Got kind of scattered areas of vesicles on a red base. Again, importantly that it sticks to one dermatome because it's coming out of the nerve from the back and stretching around, and so shouldn't cross midline, shouldn't be in other dermatomes. Although theoretically with an immunocompromised person you could have that. So again, kind of throwing it all together here now. So the suicidal ideation, kind of the way we quote unquote treat that in the hospitals, we just watch them and we have psychiatry clear them. And I think it's probably different state to state, but usually what happens when someone's suicidal is someone will write a affidavit saying like, I saw this person or heard this person say or do this, and then we'll take that and use it as evidence that like this person is not in the right frame of mind to care for themselves, and we'll force them to stay in the hospital. We can forcing people to stay in the hospital really only like cases like this or cases where they're confused, like obviously can't make an informed decision. So these were kind of the diagnoses that I gave him: shingles, bereavement, and suicidal ideation. He did, and again, super sad, but he lost his son like a year ago, and so he was actually in town for a grief conference. So like, yeah, very reasonable that he would be sad enough to potentially take his own life. Psychiatry saw him. They said he's got adjustment disorder, cluster B personality traits, which is not very specific, complicated bereavement, and then yeah, shingles, history, depression, anxiety, and shingles. So he went home on Wellbutrin and valcyclovir and PRN lorazepam. I don't know if you guys can see that down there, but um, and the thing really I wanted to talk about with this case is that again we just kind of sat and watched him. We gave him valcyclovir and we put him in airborne isolation, which again kind of weird that like airborne isolation. What's going on with that? So isolation is something that we deal with not infrequently in the hospital, and that's again kind of goal of that is to prevent spread to other patients, prevent spread to yourself, you not give them anything if they're immunocompromised. So you think about kind of the general things that we do is like we clean rooms, we clean our hands walking in between different patients. Again, probably not something that's really thought about until COVID happened a couple of years ago and everybody was in isolation, it seemed like. So just a couple words on this, different types kind of different levels. And so chemotherapy is more someone who's receiving chemotherapy. So like their immune system's knocked out. So you got to be careful what you bring into them. And so like no plants, which is like the weirdest thing, but they can't get flowers brought in by their family, which kind of stinks. Got to minimize dust around the room. Contact is pretty self-explanatory. They're all kind of self-explanatory, but like droplet precautions, which would be like influenza, like that lady that we saw earlier, probably need to wear a mask when you're in her room. And then airborne, which requires an N95 or higher, which are like those rest mat suits that I've never worn, but I hear exist. And then you want them like in like a specifically the CDC called the airborne infection isolation room. Basically, like that's taking air and pumping it out as opposed to just kind of diffusing through the unit. And then enteric is just something Cox uses. And I think we only use this for one pathogen, basically because you have to wash your hands with soap and water. You can probably guess what that pathogen is. So and there's just some, again, examples of reasons that you do the different precautions. So I don't know. I just put this in there because I was thinking about him and how he, like, we were putting him in isolation, but he's probably felt very isolated for a lot of reasons. So this has increased since the pandemic, obviously, like isolation, depression, that sort of thing. It's a real thing. I mean, it's difficult. You guys are in a difficult spot right now. Like, schooling is hard. And it's sometimes hard to see the end of the light here, but some people like really just don't see the end of the light and they see there's only one option for me. And so that's what this guy was suffering. So I wanted to bring that up. Something to think about too, and seeing him too, again, I have a young child. He had a young child who died. Think about that. It was a little bit more real. Like, oh yeah, I could see why you'd want to jump off a balcony for that. So you've seen him, you're kind of reeling in the morass of what that was, and then someone urgently pages you, again, copy paste from a page. If you or the PA could come in and take a look at 401, she is totally freaking out, ripping away at everything. I need something to sedate her or passively restrain, please. So possibly restrain. So this nurse is asking basically for you to medically put this person down so they can not deal with them, whether or not that's good or bad. A little bit shocking unless you know that nurse or potentially have spent time with patients that are like this. So whenever I get a page like that, I don't want to just, here, give them some Valium and make them go to sleep. I kind of want to like know better what's going on. And so I went up there, patient, she's wanting to leave AMA. She's not oriented. The daughter is at bedside and very tearful. So there's a situation going on. She didn't have anything plugged in. So theoretically, she probably did just rip it all out. But this kind of, she was not like that earlier. She was there, I think, in the hospital for an instemmy, maybe had some blockages in her heart. Older patient, so she's confused at least. She may be delirious, but how to handle that? So a little bit of definition up here. Hyper, hypo, and mixed phenotypes, which I don't know that it matters so much. Hypoactive is kind of hard to tell because they're going to be like not doing anything, not saying anything. Hyperactive is more characteristic of someone ripping out all their IVs and wanting to leave AMA. So Obviously, different things can cause that. So medical illness, maybe her heart is continuing to not work and she's not getting perfusion to her brain. Um, Maybe we gave her some oxycodone and now she's confused from that standpoint. She was old enough to be having dementia for sure. So these are some other things just to think about with anybody that's confused in the hospital. Mm. So I guess kind of similar to blood pressure, like because the nurse is there wanting medications or to restrain her, by which he meant like wrist restraints, have her tied down in bed. So what to do for it? So again, one thing you can do is just kind of wait because the thought process, if you give her more medications, that could make things worse, or it could make her vitally unstable, in which case she's going to get sick and need other treatments. You want to treat the underlying condition. So if they are in pain, you want to treat that. If they have some other, like if their thyroid's out of whack, you want to treat that. Uh, if push comes to shove, in my head, kind of the way I think this is kind of backed up by the guidelines too. But like if they're hitting nurses, you don't want that to happen. And if you can't talk them down, you are probably going to have to sedate them or tie them down. She ended up getting nothing. I just kind of went up there and spent some time. Like, you can't leave. I want to leave, but you can't. I really want to leave. So it's time consuming, but she didn't get any medications. She eventually was more fine. And so that was kind of a happy ending. This is from a American Academy of Family Physician article, just kind of talking about the basically don't use physical restraints if needed, unless you really need it. Don't use benzodiazepines or other sedating for the first choice for these things because you're probably going to bring on worse mental changes in the hospital. And so there's kind of the summary of that. There's no prevention for delirium and there's not any great treatments. And so it's just kind of something to be aware of and uh, something to be thinking about when people are having changes in the hospital from a confusion standpoint. So this was another Florian's question I got. I was just walking through the unit. I was going somewhere else, but there was something happening in a room for a patient that wasn't taken care of. And they asked, "Hey, Dr. Rogers, would you come pray with this patient?" That's something that I've done with patients before, and that's probably why they just like grabbed me as opposed to any other random person. But so kind of wanted to talk about spiritual care. I think you could ask the question like, is that helpful at all? And ideally, you will leave here thinking that yes, probably it is. This was a recent New England Journal article, kind of defined spiritual care as like, you can read it there. I don't need to read it to you. But in my head, the goal of spiritual care, if you're thinking about like taking care of a person as opposed to a disease, you're going to hit all aspects of who that person is, mental, emotional, physical, which is what we think probably the most about because it's extremely complex. But then, of course, spiritual is there too. And so that can look different ways, kind of some recommendations. I don't remember if these came from that article or from another one in the AFP, but spiritual history taking, so asking, and there's some different mnemonics for this that you can just help you to ask, like, where do you get your hope from? Are you involved in any organized religion? What does that look like? While you're here in the hospital, do you want someone to come and talk to you about this? Like a chaplain or like a priest or a rabbi or whoever it would be. Again, small community hospital in Branson, which is like the buckle of the Bible Belt. Pretty much all Christians, not necessarily, but generally that case. So, and then documentation. So, like when you're seeing someone like an outpatient, you kind of get that initial history of everything, including your spiritual aspects, and then you can put that in the chart, and you can use it to take care of things later. Like if they go to the hospital, you'll know what rituals or services would be important for them. And then compassionate listening. I mean, I think that kind of feels like a cop out, but I think that's true. Like when you listen to someone who's had a hard time or needs some care, that really provides a service for them that you can't get if you're just like writing medicines and treating diseases. So this was from a JAMA article. Again, kind of the goal of this is just basically to say like, hey, we surveyed patients, and yes, most of them would like their spiritual needs addressed on some level, whether that's like prayer, whether that's having someone who represents their faith come to the hospital and talk to them. So just something to impart to y'all to be thinking about. I don't know, when I went through training, this was not very handled at all. And so I just try to encourage this with any lecture I do. But then there's some pseudonyms or acronyms. So FICA, which doesn't make sense, but HOPE, which I think is a little bit easier to believe. Again, just to kind of remind you what to ask for patients that you're getting a history from. So I think that's it as far as cases and stuff. This was representative, and this is my son. This is Micah. So that's him at daycare. Yeah, he actually does really well, generally at daycare. But again, representative kind of slab of my night, some hopefully helpful pearls. I don't know if you guys want this. I could send it out if you guys want. I don't know if you guys will have that, but and then kind of as promised, kind of some helpful resources. I'm sure like getting bogged down with resources, like there's a lot out there. These are things just that I find helpful. So up to date, obviously AFP, family physicians, again, which you should all aspire to. Just kidding. Um, ICU one page is really helpful. It's an ICU doc. He got more famous in COVID, but he just like puts a lot of information about a specific disease on one page. So if you look at that, you'll like just get a better understanding. It's probably really helpful if you know nothing and you need just like a base to start from. Life in the fast lane is more like emergent, like taking care of SVT and reading EKGs, and so that's helpful. Radiopedia, obviously, radiology stuff. Pathways, just kind of like guideline synopsis. That's a newer thing. That's helpful. ECG Weekly. Actually, a student turned me on to this, but it's a guy from, I think, Maryland who just like goes through ECG cases, sends you an email a week. Super helpful to get reps in. I've found it helpful since I've started. So would recommend that. I think there's a little bit of, I think it's like $20 a year or something, so not much, but a helpful thing to use, I think. And then I do a lot of driving, so I listen to podcasts, and so these are just different podcasts. If you guys are thinking about going into like a general field of medicine, I think Herbciders is almost invaluable because it's two guys talking to an expert, and you just get a lot of good information. It's pretty entertaining. So again, not sure if you guys are podcast people or not. We don't need to survey that, but I think these things are pretty helpful. And these down here, cardio nerds, core IM, and febrile. Febrile's maybe if you're more interested in infectious disease, and cardio nerds more for cardiology. That one was over my head, honestly. So if you're like really interested, then that may be beneficial for you. But obligatory resources. There's my contact info. There's my contact info again with more pictures of my baby and my wife. But I think that's all I had. So yeah, I think thank you. Yeah, I was gonna. Yeah, we're done a little bit early. Do you guys have any questions? Do y'all on Zoom have any questions? Share this thing here. Yeah. That's fine if there's not a question. You always know you want to go. Pretty much. I think how I'd answer that longer than you wanted probably, but when I grown up, like my family was pretty healthy, so we really only all saw family medicine physicians, and so that's kind of in my head when I went to med school. I was like, well, everybody's this. Then I found out that wasn't the case, and then so then I backed up and was like, well, let me be open about going into something else, and I just liked every rotation of family medicine more than the rest of them, so that kind of sealed it for me. But again, perks, you can do procedures, you can use your hands, you can see the entire range of like human existence. There are a lot of, and I think Cox is pretty good about this, but like our Cox program, obviously family medicine, but then we've got a lot of people being hospitalists. We've got some people that are doing like dermatology only. We've got some people doing uh, like small town, rural, do everything. And so there's just a wide range of stuff you can do out of it. So yeah. Are you thinking family medicine at all? It's fine if you're not. Totally fine. Yeah. Yeah. Okay. Emergency med. Okay. Yeah. That came out of family medicine. So yeah, very similar. Yeah. 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 So other thoughts, questions? And then yeah, my phone number and email were up there just for a blip. But if you guys have questions later or thoughts or anything, by all means. to share them. All right. Yeah. Thank you guys. Thank y'all.